Everyone. I'm Eugenia Gianos at Northwell Health in Lenox Hill Hospital, and I'm here with my wonderful colleagues for our Building Bridges to the Community series. And today we're going to talk about menopause hormone therapy, talk about all of the benefits, risks, controversies, all the information that you need to help you make the right health decisions. And this is something that all of our different fields are starting to focus on finally. So I, as a cardiologist, with respect to cardiovascular risk, but my colleagues from totally different disciplines also, internal medicine and OBGYN, are very much focused on this particular topic. So any questions you may have, just go right ahead and put them in the chat. We definitely want to get to them in a minute when we're done with the talk. Okay, so I'll introduce my colleagues. So Dr. Ellen Manos, who will be giving a talk, is one of our all-star voluntary faculty at Lenox Hill Hospital for OBGYN, and she's focused in her career both on the OB, delivering babies and taking care of women and keeping them healthy peri-pregnancy, but also on the menopause period. And we have with us Dr. Brittany Katz, who is an internist at Medicine for Women. It's a practice in Westchester, and she is a certified menopause practitioner. She's a diplomat of the ABOM, and she's an assistant professor of medicine at Zucker School of Medicine and a member of our Katz Institute for Women's Health. So she is coming at this from the internal medicine side, and fortunately, we are getting more and more practitioners who are expert in this area. So we will allow Dr. Manos to share her slides and give us a little bit of an overview, and then we'll take all of the questions.
Fabulous. And please feel free to interrupt me at any time. Okay, so let's see. Let me share, get my, so do you see it up?
Yes, you do.
Yes, you do. Great. So just let me get this enlarged, put it in book form, and we're great. Okay, so here we are. This is all about hormone replacement therapy, updated about a month ago, April 2025. This is such a fluid subject. Things are changing by the moment. I tell my patients, I wish I were 40 years old again, not because I want my youth back, but I want to practice 20 more years with the knowledge that I have now. It's amazing how things have changed. First of all, we go over the myths and misinformation. I am sure many of you have heard good things, bad things about hormone replacement. A lot of women have been misled about menopause. And right now, menopause is having a moment because a lot of these misconceptions and downright misinformation have been debunked. A lot of it came from the 2001 WHI study, which started back in before 2001. And it was a large-scale study of many, many women who were taking hormone replacement. And it was stopped abruptly because of the increased risk of breast cancer and MI, which is heart attacks. And unfortunately, as a result of those discussions and those conclusions that were blasted all over the media, many women since then, do the math, that was 2001, that's almost 25 years of women that either were not treated or stopped treatment. Certainly the medical community, there was no teaching of menopause replacement and hormone therapy. Things stopped dead in their tracks. And as a result, for a generation, almost two, people were not getting the care they needed. Of course, now we look back on it, we've learned from it. And as I say, menopause is having a moment. This has been all over the New York Times. It's all over the media. It's all over Instagram and TikTok. The fact is the discussion is opened, all right, from 2000 to 2023. It's time to stop normalizing the suffering in menopause. As a matter of fact, the New York Times in the last health issue also was talking about menopause as we know it. Is it over with? And hopefully the answer is yes. All right, we can do a lot for it, whether it's hormone replacement or other treatments that are non-hormonal. So there's a lot to talk about. Current evidence, as I said, provides reassuring perspective on long-term harms and benefits from hormone replacement, but it all depends on women in different age groups. And when they're limited to the youngest age group, which in their study was 50 to 59, there's no increased risk of coronary artery disease, no heart disease associated with hormone therapy. But again, a lot of this depends on patient selection. Who is it good for? Who is it not good for? We don't have evidence-based studies that are saying it's good for everyone. So it has to be taken individually. And these are newer studies that support the opinion that hormones in women are safe in early postmenopause, especially from the cardiovascular risk. Short-term estrogen and progesterone use. And when we say estrogen and progesterone, that's because women have a uterus. And unless your uterus has been removed, we need to give you combined hormone replacement, estrogen and progesterone. None of this you have to memorize. This is all interesting stuff. We'll go over it again, but it does not significantly increase your breast cancer risk either. And again, this is something very important to individualize for every patient, because we have not only risks of fibrocystic breasts, we have genetic risk, we have family history. We have to take every patient with her own estrogen fingerprint. And women over the age of 60 to 65, it does not need to be routinely discontinued. In the old recommendations, it was okay for the symptoms, the first 5 years of menopause. All of us agree, including what used to be called NAMS, the North American Menopause Society. Now it's just called the Menopause Society. We all agree that if somebody is stable and retains their low risk to be on hormone replacement, they could stay on it open-ended. And this was just a recent article in OBGYN, our Green Journal, which analyzed finally the cardiovascular benefits and biomarkers after hormone replacement. And the conclusions were the same group from the WHI study. They just looked at the data 17 years later and saw that the LDL and the HDLs which are cholesterol models. Dr. Giannis will talk about this a little later, and certainly all our panel. The cholesterol panels were actually improved on patients who were on the hormone replacement therapy. All right, both in just estrogen alone and estrogen and progesterone. So again, these are retrospective studies, but fantastic. Full research should assess whether other progesterones will help the effect of estrogen on HDL-C, because these were done on a synthetic progesterone. We are now using a natural progesterone. Facts in physiology, we talk about the way women process their estrogen. Premenopause is the time of when you start your period until you enter your post-reproductive life. Perimenopause is the most interesting to me because that's the period of transition. And postmenopause means it's a point in time when you've had your last period, but you're postmenopausal fully when you've had a year without a period. So the only exception to all of this is premature menopause, which you may see in the lower corner. I'm looking to see if yes, I have I don't know if you can see my pointer, but premature menopause is when you have menopause at 40 years or younger. And most of us do not have that. If you have surgery taking out your ovaries or chemotherapy for any other reason that has made your ovaries not working again, and you're 40 or younger, that's considered premature menopause. That's a very specific group. Stages of menopause, we just saw this. I don't really have to go over it again, but just remember, we're not discussing here premenopause 0 to 45. We're discussing 45 to 51, or even earlier than 45. Some women start perimenopause, the transition where estrogen starts dropping, even earlier than 45. And of course, menopause over the age of 51 on average, not etched in stone, but certainly those are the two groups of people we're very interested in. This is a little too, the only reason I bring this up is because of biomarkers. Biomarkers for hormones and for menopause are important. They're not as important to treat menopause, but they're often important to define where you are in menopause. And the ones that we check are the serum estradiol, progesterone. When your ovaries stop working, your progesterone goes down and stays down. The estradiol is very variable when you're perimenopausal, but once you're postmenopausal, it stays low. And the FSH, follicle stimulating hormone, is the hormone that comes from your brain that turns on the ovary. So when you become perimenopausal, that FSH, that signal from the brain, starts working very hard. It wants your ovaries to work. It's pushing, it's pushing, it's pushing. And as a result, the FSH keeps going up, up, up. It has to work very hard, your brain, to turn on your ovaries. And eventually, when the ovaries can't work anymore, they're done. You're postmenopausal, estrogen is low, FSH is high. And these are the hallmarks when we measure these biomarkers. Okay, so why is this important? Well, life expectancy, and these were again updated from the CDC website. Life expectancy for males is 73 and a half years. Life expectancy for females is a full 6 years longer, and it's probably even higher than that. So women live longer than men. Part of it is the estrogen protection against cardiovascular disease and other issues. But also the fact is since we're living longer, we have a lot of years that are postmenopausal. So we have a vested interest in keeping ourselves healthy in terms of brain health, in terms of heart health, in terms of general physical health, because we are living longer and we are living almost half our lives, well, maybe not half, but certainly a third of our lives postmenopausally. Female causes of death, all ages, races, you see heart disease is the number one killer. Cancers are the second, lung and cancer killers, lung cancer being the number one cancer killer in women, and respiratory diseases. Now, the risk factors for death, of course, are your age, medical history, genetic history, and lifestyle. Some of this you can change, some of this you can't. Obviously, age, time marches on. You can't affect it. Lifestyle, you can. Genetic history, you cannot change your genetic history, but you can modify it. And of course, your medical history depends on lifestyle and everything else that comes with it. All right, so to the risks and recommendations. This is really the crux of this talk. How do we know when to bring things up? How do we know what to ask for? How do we know that it's safe to have hormone replacement therapy? It's not for all women. Okay, so age of menopause is important because no one's going to argue if you're in premature menopause, if you're early at 40 years old and average menopause is 53, you're being cheated out of 13 years to 15 years of estrogen. And estrogen keeps us healthy. We're seeing more and more of this for these following reasons: autoimmune diseases, more common premature menopause or early menopause, certainly. Risk reduction surgeries, women who have genetic testing and are BRCA positive want to have their ovaries out the minute they either become perimenopausal, or some institutions are recommending at age 40 that their tubes and ovaries are removed. So surgical menopause, risk reduction, and genetic factors, we're seeing more early and premature menopause. Early intervention is really important for that group. Again, perimenopause is the time of transition. It's all about when do we start hormone replacement therapy? Is it just supplementation when we're starting to transition and our estrogens are dropping, but we're still having cycles? You can have regular cycles, irregular cycles, but this may be a good time to start estrogen supplementation, not replacement. It's often more subtle in timing and symptoms. It can be multi-system. It can happen with irregular cycles, low libido, sleep disorders, lack of concentration, the infamous brain fog. All of us have brain fog when we're overwhelmed. This crazy world is going nuts. We have brain fog just from what's happening in the world. At the same token, when that's compounded with an irregular sleep pattern, low estrogen hormones, it can really be debilitating. It's the most challenging to treat, frankly, because your ovaries sometimes are working and sometimes aren't. So as a result, you can have irregular bleeding on or off your hormone supplementation, and can be quite a challenge to get this regulated for the patient. But the take-home message is perimenopause often triggers the conversations with patients, leading to cardiology referral, internal medicine referrals for people who know about hormones, certainly, of course, to your gynecologist to start the discussion. Is it right for me? Let's talk about it. So no longer shrouded in mystery. Of course, postmenopausal, all right? Average in the USA, as I said, is early 50s, but it's a bell curve. You can have it as young as 41, 42, getting to menopause, or as old as 64. Those are either side of the bell curve. But 95% of women stop their periods for a year between the ages of 45 and 55, and average in the United States is about 52. As previously defined, a year without a period. You start getting symptoms both in your entire body systemically and locally in the vulva, vagina, bladder. It can lead to multiple systemic conditions. Low estrogen is a culprit for osteoporosis, for coronary artery disease, for high cholesterol, which of course is related to coronary artery disease, and type 2 diabetes. It slows down your metabolism not having enough estrogen. It makes you not sleep well, so you're exhausted and fatigued. You don't even want to exercise. And of course, the trend towards glycemic syndrome, which is pre-diabetes, will eventually lead to type 2 diabetes in many women. So we want to catch this early. But risk stratification, meaning we have to know if you as an individual are a candidate for hormone replacement. Very important, your risk factors, but also what you want out of the situation, what your doctors can handle as well. All right, so as we see, low estrogen being the culprit, and also low progesterone, although progesterone, as I said, is little less important in terms of health issues, and we'll get to the specifics in a little while, can lead to psychological changes, cognitive changes, the new, very interesting studies about Alzheimer's prevention and early estrogen replacement. Genitourinary syndrome of menopause, GSM, means dry vagina, dry urethra, bladder issues, pain with sex. Systemic conditions we just talked about, type 2 diabetes, high cholesterol, heart disease. Hot flashes, of course, that's one of the biggest signs and one of the biggest reasons why people come in. But hot flashes can now be treated in other ways besides hormone replacement. What about the poor patient who has breast cancer who can't take estrogen? Luckily, now we have alternatives to deal with hot flashes. But nothing works better than the estrogen. And of course, the physical changes, as we talked about. Losing height from osteoporosis, getting a little belly from type 2 diabetes or glycemic syndrome, slowing of the metabolism. Also, flare-ups of any sort of autoimmune disease, whether that's multiple sclerosis, rheumatoid arthritis, Hashimoto's thyroid disease. Any autoimmune disease can flare when you get into menopause. So what are our goals of treatment? Not just to make the patient happy, but we want relief of the symptoms using the lowest effective dose. And always you can have more, right? We want to try to do it on the lowest dose effective. This is coming into question when it comes to cardiovascular disease, because if you don't have enough estradiol in your bloodstream, you may not be getting all the benefits for the heart. And we'll talk about that later too. Extended use for more than just a few years. Of course, it can be considered. You get rid of your hot flashes, you feel like $1 million, you feel reborn, you have energy, you can have sex again without pain. Why would you want to stop? You probably don't want to stop, but this is why you have to be reevaluated on a regular basis. Hormone therapy is optimal treatment for most symptomatic women for hot flashes, the dryness of the vagina, including sexual dysfunction, bladder dysfunction, and osteoporosis prevention. These are the FDA-approved reasons why people go on HRT. They don't talk about anti-aging. They don't talk about feeling great mentally. They don't talk about cardiovascular disease and Alzheimer's prevention because we don't have those evidence-based studies yet to say that it is better to be on it. Okay, so it has to be shared decision-making between the patient. Education is important, and it's important to develop a personalized treatment plan for you as the individual patient. It's not all the same. Okay, so risk stratification. This is really important for people to understand because sometimes in the red, there are contraindications. You cannot be on hormones. And these are the reasons why. Unexplained abnormal vaginal bleeding, until we figure out what that vaginal bleeding is all about, you cannot have hormone replacement. If you have active stroke or a history of stroke, TIA, which are mini strokes, transient ischemic attacks, if you've had a heart attack, if you've had a PE, which is a pulmonary embolism, or if you have VTE, which is thrombotic disease, right? Venous thrombotic disease, where we know you're high risk for developing blood clots. If you have one of the genetic known inherited clotting disorders, it's not smart to be on estrogen because estrogen itself can increase your risk of a blood clot if taken improperly. And even if taken properly, it raises your risk slightly. So we don't want to add fuel to a fire if you have a pre-existing condition like this. If you have a known, suspected, or history of breast, uterine, or other estrogen-dependent cancers, which there are many of, but breast and endometrial, meaning uterine cancer, are the two most important. If you have a history of that, nobody's going to really feel comfortable giving you hormone replacement. And that's because your risk of recurrence of breast cancer may be higher, and your risk of endometrial cancer may be higher, your risk of recurrence. So often we say when people have breast cancer, you don't die from your initial breast cancer. It's the recurrence that can occur that really can affect you. Same thing with uterine cancer. If it's caught early, stage 1, 2, sometimes even stage 3, but stage 1 and 2, you should be cured. But it's an estrogen-dependent cancer. We don't want to encourage recurrence. The biggest source of controversy right now is women who've had a history of breast cancer get both breasts removed. So they've had bilateral mastectomies. Is it okay for them to be on hormone replacement? And the answer to that is it's still unknown. But certainly there's a little bit more flexibility in those patients. If you have active liver disease, estrogen gets metabolized in the liver. So active liver disease is a contraindication. And if you have a 10-year cardiovascular risk of having atherosclerotic heart disease greater than 7.5, this is something that the cardiologist will calculate according to a risk profile. They stick your numbers in and give you a number. If it's higher than 7.5, you really shouldn't be on HRT. The relative contraindications are a lot of women. I wouldn't say 50%, but probably 20 to 30% of people on hormone replacement have relative contraindications. Because if you have diabetes and high triglycerides, you shouldn't be on it. But what if you're corrected? What if your diabetes is in control and your triglycerides are in control? Same thing with gallbladder disease. If you have active gallbladder disease, that's one thing. You can have increased risk of gallstones being on hormones. But what if you have your gallbladder out and then you're not at increased risk anymore? A benign meningioma, that's a benign tumor of the meninges, the surrounding area of your brain and your spinal cord. A bit controversial. They used to think that meningiomas can grow from estrogen replacement. Now they're not so sure. So it's something that's a relative contraindication. If you're high risk for breast cancer, what if you have a score that's 20%, 1 in 5 that you're going to develop breast cancer? You have a strong family history, maybe relatives with BRCA1 or 2. Maybe you have dense, horrible fibrocystic breasts, or you've had a precancerous condition. We want to be sure that you know what you're getting into. Migraine with aura. Now, migraines definitely have many different presentations. So the ones with aura, which are, those visual disturbances, speckles, sparkles, whatever, those have an increased risk of stroke in and of themselves. So if we add oral estrogen therapy to that, especially if you've ever had an issue with migraines on birth control pills, et cetera, that could be a contraindication or a relative contraindication. We don't give oral estrogen therapy hardly ever anymore, so this could be gotten around. And of course, the 10-year cardiovascular risk between 5 and 7, a relative contraindication, but again, we could be flexible about it. Of course, the next is the perfect candidate. How many of you out there are the perfect candidate? We'll see. FDA approved indications, hot flashes, osteoporosis prevention, and treatment for the dryness, which, by the way, you don't have to be on hormone replacement for GSM because we can give you local cream. Again, a big distinction we'll talk about, but these are the FDA approved indications. Other common indications are sleep issues, especially if you're having 10, 20 hot flashes a night, mood disorders. Of course, you're going to be in a bad mood if you're not sleeping well, joint pain, sarcopenia, which means loss of muscle. And we're seeing a lot of this with our patients now on Ozempic, Mounjaro, all of these medicines. They're doing beautiful jobs for people with chronic obesity and weight loss, but we have to be very careful with the muscle loss. Okay, it's very important that muscles are maintained. Estrogen helps with that, but it's also a matter of strength training. And now we're linking low muscle mass to Alzheimer's development also. If you've had recent menopause, your normal weight, you don't have high blood pressure, normotensive, you have an active lifestyle, wow, you are the perfect candidate. And your cardiovascular risk less than 5%, sounds good. Then you have to have the discussion with your providers to see what kind of hormone replacement you'd like to be on, delivery system, follow-ups. We had some case studies. I'm not going to go through these. These were more academic. We could always go back to them if needed. But for me, these are your key takeaways. Think about all of this. Betty Davis said it well. Old age is not for sissies. Well, it is true. Just because we live 30% of our life postmenopausally, do we have to suffer with osteoporosis? Do we have to suffer with hot flashes, low libido, not thinking straight? I like Theodore Roosevelt's better. Old age is like everything else. To make a success of it, you've got to start young. You don't become perimenopausal and postmenopausal overnight. You bring your history with you. So even as a 20 and 30-year-old, if we can get people into active lifestyle, more vegetable-based and less animal proteins, higher protein, low glycemic, active lifestyle, of course you're going to go into your 40s and 50s a healthier person. But you have to intervene early. You have to individualize for every patient, and you have to revisit, meaning even if you're on hormone replacement, you have to be a responsible patient, go for your studies, your mammograms, your transvaginal ultrasounds if needed. You have to see your doctor on average twice a year. It's a medication. Even though it's a natural medication, it's still a medication. Thank you.
Wonderful. Thank you. That was excellent, as always. I think a lot of key points that, for many of us are things that are not discussed that often. And as you said, it is now at the forefront in many different places. So I'm so happy to see the overview, and hopefully everyone else can benefit from this. Okay, great. So I want to give Dr. Katz a minute to sort of just anything in particular that, jumped out, for you from the talk that you want to highlight. I know this is an area that you focus on as an internist.
I think the important thing you mentioned is like how quickly things are changing. And honestly, like every week I'm getting new studies that really like, everything we thought we knew is different. So even in terms of the absolute contraindications, the blood clots, there's some suggestion that maybe transdermal estrogen is actually okay in people with blood clotting disorders, and that could change. So I think women are doing a much better job than our predecessors of talking about this. So bring it up every year to your doctor, because even if there's not a therapy for you this year, like I said, it could be next week that things change. So
Absolutely.
it's something we have to keep talking about with our patients. And of course, our patients need to keep talking to us about that as well.
I think that's a really, really important message. It used to be that, everybody was on oral therapies, and the oral therapies always went through the liver. They affected the blood clotting. Then they developed the transdermal methods. Now there's some research in sublingual methods, troches that go under the tongue. It's still going right into your bloodstream. They have to really normalize the dosing, but that also is something very brand new. It's not going through your liver. It's not going through your GI tract. It's getting right into the bloodstream, but you're actually sucking a lozenge. I mean, it's amazing. So all of this stuff, like you say, is a continuum. So keep asking the questions. You're right. Every week, every month, once a year, you go for your checkups, bring up the discussion.
And also, don't sleep on vaginal estrogen. There are so few contraindications to vaginal estrogen. I think almost every woman should be on it. So it's something that we don't always ask about in our visits. Well, I do now, but talk to your doctors about it. Don't be afraid to talk about vaginal dryness, painful sex. These are things we can help you with. Men talk about it all the time. We've got to talk about it too.
Yes, absolutely. I think that, it's so important to have these conversations and just ask your doctor, because, hopefully your doctors are now maybe more attuned and asking more, hopefully. But even if they're not, you would ask for what you need when you go to a store, when you go, for your finances or whatever. You really need to ask the questions. And I think the data is interesting. Like, we've made a lot of conclusions over the year based on whatever data we had. But you pointed out, Ellen, that, a lot of the older studies were done with therapies that we're not really using that kind of oral estrogen either. So that makes it kind of confusing as to how to interpret the data. But at least the vaginal stuff is very localized, as you both have explained. It is not, noted systemically in the blood. So it doesn't have the same risks as oral therapies potentially might have. So that's really, really a great, great point. So should everyone, I'll start with you, Dr. Katz, again, should everyone just be on it? Like, a lot of folks are just out there saying, oh, if you're not taking them, you're putting yourself at risk. Is that true?
Yeah, so there's a lot on social media, and I love that women are talking about it, but there's also like a little bit of a swing of the pendulum to the wrong direction. There are women who have no symptoms whatsoever, and it's the same as any medication. We say statins prevent heart disease, but in someone who has no symptoms or no high cholesterol, no heart disease, should we just put everyone on it? We don't have the evidence to suggest that at this point, that it's really important for longevity. So I would say that's a discussion to have with your doctor. But if you're having symptoms, absolutely, but you don't have to feel like you're missing out if you're not on it, because not every woman needs it.
Right. I think
So who
also,
should get it is the question. Maybe Ellen, you want to tell us and also comment.
well, I think to bring up the point that Dr. Katz said, you come with a history and you come with a family history. So part of it is not just who you are, it's also part of the whole genetic picture. If there's really a high risk of heart disease in your family, or a high risk of Alzheimer's in your family and you're petrified, we don't have evidence-based studies yet to say being on hormone replacement can help to prevent Alzheimer's. But the studies are becoming more and more compelling. So what do I do with this patient who is 50, starting to get a little brain fog, but maybe not, maybe no symptoms at all, but has a strong family history of Alzheimer's? If I wait too long, I may have closed my window. So is there a place for clinical trial like that? Okay, the patient has to be told there is no real proof that it will prevent, but because timing is important in prevention of Alzheimer's, because we know that treatment of Alzheimer's doesn't work. Once it's there, the treatments are not working. So again, this is the kind of thing that I'm talking about. I don't know from the cardiovascular point of view how you feel about it, Dr. Gianos. If a patient comes and says, oh, I have a strong family history. My dad had his first heart attack at 49. I have a grandmother who died of a stroke, and they do have cardiovascular history. It's a different person, right? And maybe the father was a smoker, maybe he had super high cholesterol. Maybe you have more markers to use to stratify those patients and say, gee, maybe your elasticity will maintain better if you're on early estrogen replacement, but you also need statins, right? So, how important is that kind of family history and genetic history in your kind of case, cardiovascular wise?
That's a great, great question. So I love the quote that you had at the end, from Theodore Roosevelt about, that you start early in
Right.
terms of, treatment, because that's how we approach cardiovascular risk. So you start really, really early. And we're seeing a lot of these patients who are being considered for menopause hormone therapy to determine exactly the risk stratification that you talked about in your talk. Is this patient too high risk from a heart standpoint that we don't want to put them on because we're putting them at risk, versus they're completely safe, there's no concern, whatever, we put them on it, or they're sort of borderline, but we can optimize a few things and then feel more comfortable putting them on it. Okay, you know what, your cholesterol is a little on the higher side, your risk is not tremendously, but if we can keep that, under control, if we've assessed, for maybe some premature plaque, did a coronary calcium score, sometimes we'll look for premature plaque, even in some women, if we're really not sure in terms of their risk, in starting. But in terms of the genetic risk, it's a tough one because, again, we don't definitively have that data to say, okay, if you have a strong family history that we put you on this, it's going to prevent.
Right.
Obviously, that was the thought early on, and this is why a lot of these studies, Women Heart, Initiative, all that's what they're thinking. Look, estrogen goes down, a lot of these risk markers get worse, your heart attack and stroke risk goes up. Why don't we just give you some estrogen? It'll, benefit you, of course. Like that's why they did the studies. But again, we don't yet. So we're sort of not necessarily using it for that, but we are definitely, assessing all of the risk as much as possible to sort of be sure that they're safe. And a lot of women were allowing them for a change. A lot of cardiologists were like, no estrogen ever in any of these women who are postmenopausal. So at least we're allowing women who are symptomatic to get their therapies, hopefully.
Right. Dr. Katz, can I ask you a question? So when you get a patient who comes in wanting to discuss hormone therapy, what are your baseline studies that you insist on that before you even talk to them? Not about local therapy, because local therapy you can give to, like you said, every woman should probably be on local therapy postmenopausally. But if they want to talk about systemic therapy, what do you use as your baseline studies that
Oh, that's a
meet
great question. So the first,
criteria?
the first thing we have to do, of course, is a family history, their own personal history. But then if we're doing lab work, I think I like to check their cholesterol first before we consider options for different estrogens, and then their liver and kidney function before we add any medications. A lot of patients come asking about hormone levels, and I just don't think they're necessarily helpful in the treatment. Like you mentioned, is, do we have to trend the FSH? No, like that. We have to go by your symptoms in order to decide what level estrogen you need. So sometimes we'll do like those as a baseline, but we don't necessarily have to trend them unless we're using testosterone therapy, which is a whole other discussion to have.
Right?
And then the other thing is depending on the symptoms that bring them there. So I've had women that come in and say, my main symptom is fatigue. Well, just because you're perimenopausal doesn't mean
Right.
you can't have other things. We've got to make sure you don't have a thyroid issue. We've got to make sure you're not anemic. We have to assess your mood. You can have depression from menopause, but also depression presents itself at this time of life as well. So we have to kind of do a full assessment of the symptoms that brought you here to have this discussion and how we can manage those as well. But I think the menopause piece of it definitely has to be a major part of the discussion because it impacts every woman.
This is great. And don't forget about the mammogram, right? You want to
Of
make sure you
course,
have a negative
yes.
mammogram. So the reason I bring this up is because now there's all these online services that give hormones over the internet. And they're really some very good and well-intentioned groups that are out there that are giving hormones online. You get an online doctor who asks you some questions, but it really falls short of a full exam, right? I mean, you're not getting blood tests unless they're ordering them. You're not having a mammogram. You're not having a physical exam. So I want to make sure that people who are listening to this discussion are cautious when they go on to the online world of hormones. Because, and I'm not even talking about, things that are available on Amazon that are natural hormones, this kind of stuff. I'm not talking about that. I'm talking about these online platforms for hormone replacement therapy. It is really great and important to bring out the information, but I hesitate to say this is safe, really. I mean, they're smart people, and I'm sure there's really good doctors on board, but they're doing it online, right? And we need to be sure that we have the data before we feel comfortable giving hormones to our patients. So the lab results, like you say, ruling out other things. The 40s and 50s are a hard time for a lot of women. Your kids are teenagers, your parents are getting old, they need you, you're sandwiched between your life, your parents, your children. And so, like you said, anxiety, depression, a lot of stuff can happen that's not perimenopause. And sometimes you need a human contact, whether it's your internist, your therapist, your gynecologist. You need to be evaluated properly. So that's the big thing for me. I don't want hormone replacement thrown at people. You have
It's
to
a
be thoughtful.
continuity of care issue as
Or-
well. Like exactly how you said, these are follow-up visits. We're adjusting medication, we're discussing new symptoms that arise. So you need to have that established care, and it helps to have a provider who knows you well, so they
for
can
sure.
see the differences. And sometimes things you don't realize were a big symptom change a few months later. So you have to have that relationship with your provider. So it is a very personal discussion, and I do think it really helps to have a provider that you're seeing regularly and can really follow well-rounded.
Great.
Yeah. And to
Agreed.
your point, Brittany, from earlier is just what you're blaming on menopause. I feel like it's like COVID and menopause and certain things have become like the blame for everything. Sort of, oh, it's because of COVID that I didn't exercise, because of COVID, whatever. Same thing with menopause. I feel like, there are certain things that both men and women as they age, there's a tendency for your metabolism to slow down. There's different things that do occur with aging, and then other things that are environmental that, Ellen pointed out, what's going on in the world and stresses and things like that, that do have an effect. So even, what we do typically see in menopause is a lot of cardiometabolic changes that you described. So you do see that the bad cholesterol, both the LDL and the triglycerides go up, the HDL can go down. You do see that, sugars can go up, some weight gain can occur around the belly, things like that. But there's also some of that also occurs just with aging, even without menopause. So I think, and like really being objective and saying, is this because of menopause, or is it really because for the past 2 years I stopped walking entirely and
Right.
I'm not eating well? Like there's a lot of things that you have to consider. And making sure, like you said, you have the right doctor who's evaluating everything. What about lifestyle also? Like I know we're talking about a lot of the hormone replacement, but are there things that women can, focus on just in general for menopausal symptoms, and what to sort of be recommending?
Well, I mean, for me, certainly I talk to patients about strength training and building muscle and higher protein diets and lower glycemic diets because, and I hate the word diet, I mean what you're putting in your mouth. It's not a
Right.
diet per se,
Mm-hmm.
it's what you're choosing to eat. And because metabolic rates slow down and the tendency with age, let alone menopause, is to become more glycemic, meaning you don't tolerate your carbohydrates well anymore. What you used to be able to get away with, you don't anymore. So, and you need to exercise twice as much to take off the weight that you used to say, oh, I can lose 2 or 3 pounds if I just shut my mouth and not eat my Twizzlers. So it becomes more of a lifestyle issue with increased cardio, high intensity training, and less carbs. So again, it doesn't have to be radical. We're not saying no carbs. We're not saying you can't enjoy yourself. We're not saying don't have that glass of wine when you're out socially with your friends and family, but we're saying limit, choose your carbohydrates, and decide how you're going to tackle this. And it's not easy for a lot of women. And it's certainly not easy when you are behaving really well and the weight still doesn't come off.
Yeah.
Or the redistribution happens. You're the same weight, but the redistribution happens.
Right.
So, it's hard to lecture somebody when you're not doing it yourself. No, I'm not talking about me. But all of us, live busy lives. So to fit in your cardio at least 3 times a week, 20 minutes at a time, to fit in preparing healthy meals, it's a challenge. But I think those 2 lifestyle things about increasing your activity and decreasing the total amount of carbs during the day is important. I think that's simple and straightforward. I also refer my patients, if they want, there's a great platform out there called Nourish. It is a Zoom platform for nutritionists, for registered dietitians. It is fabulous. They take all insurances. Your doctor has to register you, and you give a diagnosis. If a patient wants to lose weight and she's a little bit pre-diabetic or she has high cholesterol, you write these things down and they match you with a nutritionist on Zoom. And it's really made it very easy for people to have that interface, because some people think they're doing the right thing and they're not, right? Something as simple as what to snack on at night if you're up all night delivering a baby, or if you are a college student and you're cramming, what is the best thing to do if you don't want to be high glycemic, or a menopausal woman who's a little stressed and I used to have 2 glasses of wine to relax and now I really shouldn't. I mean, there's a lot of gray zone, but Nourish is a very good tool to use. So keep that in mind.
Thank you. No, that's great advice. I think that for partly the the cardiometabolic sort of associated things, diet and exercise, or, healthy eating and exercise really does make a difference. And even for your mood, your concentration, what you're eating is extremely important. I think, that can actually, even with these symptoms, some of the symptoms of mood swings and, concentration, things like that. Granted, they may be very much tied to the hormones, no question. But if you're then eating bad carbohydrates, shall we say, like poor quality diet, processed foods, not nutritive, whatever, you're going to worsen your symptoms in all likelihood. And exercise can actually have very, very significant benefits. So I think definitely, keeping that in mind. Also through our health system and usually most of the health systems, we're part of the CATS Institute, but they do have both dietitians available, that we partner with very regularly, and a lot of certified, clinicians in menopause. So for people out there who are just not finding the right people, there are, definitely clinicians out there who are expert in this and expert in lifestyle as well that you can work with.
We also have a menopause lifestyle coach that in addition through CATS Women's Institute, which is a new program. And right now we have one and she's fantastic. Hopefully we will have more because she's been in demand. And in addition to the nutritionists, she's got some tips for fitness, but other lifestyle changes that you can make, meditation, ways to combat menopause specific symptoms. And that's something that's becoming increasingly popular. I'm seeing a lot more menopause coaches. So, other ways to manage lifestyle, again, can be very individualized.
Right. That's great.
Thank you. So yeah, this has been really, really informative. I think, the topic is out there now. The conversations are being had, which is great. And yeah, I think keep all of the important points that you heard tonight in mind, that, If you are having symptoms, you should talk to your doctor about it, and you should be considering therapy. Make sure somebody is evaluating you very well, not just sort of giving you the treatments without knowing. And continuity, partnering with someone like Dr. Katz, Dr. Manos, to be able to sort of keep you healthy, I think is really, really important. Excellent. So thank you everyone for joining us. And thank you to our guests, and also to Monique Carrera-Tegla for all her help in putting this together. Have a good night.
Thank you. Thank you for having us.
Thank you so much. This was wonderful.
Thank you.
Thank you.